All right, Dana, thank you so much for joining me. Now, before I hit record, I was telling you I don't even want to say anything. I just want to sit and listen for 40 minutes. But you had a question that I said that would be a perfect question for us to start the interview with. So ask me the question you were just asking.
Sure. So what I asked Tony was, as I've done a few of these podcasts and been interviewed by some really interesting smart folks that are really plugged into the stresses and the stressors of PT owners of outpatient clinics, I feel like there's a way I could be better connecting with what therapists are worried about, thinking about as I try. I really feel that there's an important message that I don't want to get missed because I'm too far removed from speaking the same language. I did speak this language fluently for a long time, but I know that I'm probably missing some of what would help me get this message across better. So if you have any thoughts about that, that would be
Yeah.
amazing.
Well, I'm gonna give you a little context on me first. I
Great.
I had started back. I wasn't a physical therapist when I owned a physical therapy practice. I was a personal trainer. I had a bachelor's degree in kinesiology. I loved like movement and movement science and all that stuff. I did a 1 year like employment at the hospital outpatient clinic as an exercise tech. And I share this story a lot. I talked to the director of rehab back then. His name's Scott Porter. He's down in Florida. I ran into Scott for the first time in like 15 years at PPS a couple weeks ago in DC. It was so
Wow.
great to see him, but he was the guy that like introduced me to the world of physical therapy. I'd never heard of it, didn't know anything about it. And I said, Scott, how do I open a physical therapy clinic? And he took me through the typical, you probably remember this. You get first you become a PT. I wasn't a PT. Then you work for a hospital for 5 years. Then you make all your connections with the orthopedics. Then you go out and you open your own clinic and then they will refer to you. And I was like, Scott, I'm not waiting 10 or 15 more years. I'm going to open now. And so within like 2 or 3 months of that conversation, I quit the hospital. I rented a space. I turned it into a personal training studio. And then I found an amazing physical therapist who was a traveler at the time. And I was like, Kathy, please come help me. All of these personal training clients need physical therapy. They just don't know it. I need to turn this into a physical therapy clinic. Well, long story short, Kathy's my wife. We have four amazing boys. We grew this
Wow.
business together before we got married. Then we got married. And so we grew to 5 locations, three in Florida, two in Ohio, all private practice, outpatient orthopedic primarily. And, when I heard your message, and this is how I wanted to connect to you,
Yep.
you were really the first person bringing what I'm going to say, and I'm not saying this to be offensive to other people, but a message that sounded logical to me. Like when I see people complain about something, but then the real world is very different and the two don't match, I'm like, there's
Mhm.
something wrong. We're missing something. And
Mhm.
so, what I love to hear from you is
Mhm.
you really were the first one to say, look, we're not even recognized, as part of the team. We're out in the shadows, kind of like we want to do all these things. We know we have this depth of knowledge, but nobody else
Mhm.
knows about it. And so I think that's the message that clicked for me. And that's what other therapists need to hear. And I don't know, and I want to hear now your background, where you came
Mhm.
from. I know you were a physical therapist, but I don't know anything
Mhm.
else because you seem to have been in the room about and around these conversations that I've never actually heard. So take me through your progression. Like, where did you start? How did you get to where you are today?
Okay, great. So, perfect starting point. So, I am still a therapist and I still practice just a tiny bit. I still have a little gym in my house and I see friends and family, which I really enjoy seeing, like, newly injured, new pain. I have a lot of fun with that still. And I try to keep up with my skills. But I became a therapist in 1998. So, I am an old timer. I
Sure.
practiced in acute rehab. I practiced in outpatient neuro. I opened an outpatient PT clinic with another therapist for a chain, but started it from the ground up. I did early intervention. I did years of home health. And that's, I think, part of why I have the perspective I do is because I've either worked with or seen literally everything. I mean, I have either interacted directly with or worked in basically every site of care. And by doing that, it forces you, at least for me, it forced me to look at the big picture constantly, right? So I was in home health, and then I started to get real. I was starting to feel like, boy, this is just this cycle of seeing patients who just end up coming back on service, right? Who go back into the hospital, chronically ill patients. This is not making a whole lot of sense. What are we doing wrong here? And so I started working on committees in home health pretty much from the day I started. But having kids, right? You're kind of in and out. I was doing per diem, I was coming back and forth. But I figured out who in the home health agency was the person who like was really open-minded, who like could think about things in a big way. I never limited that to the therapy department. Never, never. And that person, that leader, helped to mentor me in a way and pulled me into the kind of clinical liaison role that I know is not too uncommon for therapists, but was only nurses from the day this particular individual started that program decades before. It was only nurses. And so going in as a therapist to skilled nursing facilities, acute rehab facilities, and seeing I mean, honestly, a lot of times a mess. Patients who just really hadn't been cared for, they had no good plan. Their families weren't taught what they had to do. They hadn't done car train, like the basic things, right? Going home, coming to home health and not being ready. I just knew there had to be a better way and started thinking about, okay, what can we do to fix this? I did some proactive work with skilled nursing facilities to just ask them to do different things to try to prepare patients better to come to home health. But right at that time, I got lucky. The Affordable Care Act opened up the first accountable care organizations, and our health system joined one of the very first accountable care organizations. And we knew we had the background and the knowledge to start a transitions of care program with loads of opportunity. And the opportunity was to help the like complex, chronically ill patients cycling through the system, right? Never really getting what they needed and making sure they got they had good care transitions, they went to the right places, and they ended up back home, right? So all of this was very good timing. And I guess in doing that, I helped to build this transitions of care program. It was wildly successful. We joined a number of programs through the Center for Medicare and Medicaid. So some episodes of care models, the Medicare Shared Savings Program. I built a team of therapists and nurses. And we worked from the hospital all the way in discharge planning, all the way through to skilled nursing and home health, and even outpatient at home therapy to build out excellent care experiences for patients. And with aligned incentives, meaning us as program operators would benefit from this better care and better outcomes, everyone had the right incentive to do better by patients, right?
Right.
And so that's where I got my first taste of, oh boy, incentives are really everything, right? And there's a whole lot about other parts of the healthcare continuums, it's incentives that therapists just don't even know about. So let me stop there before I keep going and see if there's anything to clarify.
Well, I think that's huge because that was your introduction. That's how you got into meetings that the rest of us wouldn't be part of. That's how
Yeah,
you got to see perspectives that the rest of us wouldn't have seen. I'm guilty of it. You get such tunnel vision in
of
outpatient
course.
ortho private practice, and so when I use the words even physical therapy, I've got such a clear image of what I think that is, but that's
Yes.
nothing like what a home health therapist sees when they say physical therapy, or a pediatric
Right.
therapist or a neuro-based therapist or anything else. So, I love to hear those stories when therapists are getting in rooms that therapists don't normally belong in.
Mhm.
I would love to hear more about incentive alignment. We've talked about
Mhm.
this before on other podcasts with other guests. It's
Yep.
like, what do you see as maybe the disconnect? Because we always say, well, we want to align incentives. We want to do the,
Mhm.
move everybody to the,
Yeah.
but how are they disconnected right now? What is the mismatch in incentives right now that you see as big problems?
So I'll first answer that by backing up just a little to
Yeah.
say part of the reason therapists don't think about these things in the way that we're describing and how I will paint a clear picture of malaligned incentives and how we fix that is that when Medicare moved to a PPS system and we lumped therapy into essentially a cost center, right? In hospitals, therapists are a cost center, skilled nursing cost center, IRF cost center, home health cost center. And because they actually made some changes in the last few years, we're even further down the cost center line. So, in all of those parts of the physical therapy continuum of care, therapists are bringing in no dollars. I mean, they are not directly responsible for any billing whatsoever. They're a requirement, right? They're a regulatory requirement, but they're not billing for services. And so therapists' voices have been very small, right? They're a requirement. They're not they're not someone to bring to the table because they're going to help build our business further. It's just not the reality, right? So that's why we're really not in those rooms. I'm going to give you a hospital example of malaligned incentives. So, as you know, probably a lot know, but if you don't, hospitals are paid. And I'm going to use Medicare as an example because everybody kind of follows Medicare. Medicare and hospitals are paid in what they call a diagnostic related group payment. So it's a one lump sum payment, right, for all services except the physician, all services. At the end of the stay in the hospital, the coders will look at the stay and they'll use their coding magic to figure out which of the DRGs that patient belongs in. That DRG is assigned to the patient. They add some risk adjustment factors and other things. And then that spits out what the hospital's paid retrospectively, right? So everything just about is included in there. Physicians, all the physicians' visits bill additionally. So surgery, right? You see the internist, the cardiologist, all of them, they're billing Medicare Part B. So you can see why they have a seat at the table, right? They're bringing in business and they're billing for business. Um, so when a patient's in a hospital, they know, everyone in the hospital knows they're getting their DRG, right? That's what they're getting one payment. It doesn't matter how long the patient's there. So what are the hospital's incentives, right? Generally, let me ask you, what do you think the number one incentive of the hospital is when they're getting one lump payment regardless of length of stay?
Get them out as quick as possible without getting them back in too quickly.
That's right. Now, readmissions, yes, there's a penalty, but it's still not a real strong incentive to prevent
Sure.
readmission. So, yes, the idea is not. So, what are we not worried about if we're worried about getting them out quickly? We're not worried about keeping them moving. We're not worried about patient education. We're not worried about identifying really, truly what their home situation was or figuring out who their primary care doctor was or teaching medications well or transitioning them to the best site of care. None of that has any impact on the hospital's payment at all, right? You do
Yeah.
have some quality payment programs that are adding, some, I would say, relatively small penalties if you're readmitted with certain conditions quickly, the hospital readmission reduction program. But besides essentially that, there's not great incentives to take good care of patients in terms of keeping them out of the hospital, keeping them moving, right? Setting them up for success for the future. This is just not how we set the system up. So, one way we're aligning incentives with hospitals is episodes of care models. I had talked about this a little bit perhaps on one podcast, but what an episodes of care model does in the acute setting is they say, CMS, let's use CMS again. They say, okay, we're going to figure out for this DRG. So let's say it's a hip fracture, right, with an ORIF. We are going to assign it with this level of complication, this target price. And again, it's adjusted a little based on the composition of that individual, where they live, et cetera. And that's going to be the target price for not just the hospital stay, but for X period after. And we're going to allow everyone to bill normally. But then if that episode, let's say it's 90 days, which they have been in the past, if that 90-day episode ends up being higher than the price that we set, nobody's responsible for that spend except you, the hospital. You are going to be responsible if that patient stays in the skilled nursing facility 3 times as long as we would expect them to, or that patient's readmitted on day 60 because they didn't get back to their PCP and they had a medication complication. So, in other words, in order to get the hospital to care about things other than getting them out quickly, right? And of course, let's back that a little bit. You have to have good quality metrics, otherwise you don't look really good, right? In
Sure.
the eyes of consumers if they look. So, a few things. But if we say there's going to be a $10,000 penalty to you if this patient stays in the skilled nursing facility too long, or goes to skilled nursing when they should have gone home, or goes to inpatient rehab when they should have gone home, those things will add up when it's every patient with a hip fracture doesn't reach their target price. So that's a program that is active right now in 36 diagnostic related groups. So does that, like, that's aligned incentives. Now,
Right.
if we put the hospital aligned with all of those other dollars, caring about those other dollars, now we're going to do a way better job keeping them moving, getting them to the best home health agency. And if they need to go inpatient, the best collaborative post acute settings. And that makes a big difference. It reduces spend, it improves the quality of care, and it reduces the chances that, complex patients cycle the system over and over. And I think therapists can get behind that 1,000%. So let me
See,
stop there.
so I can totally understand. I remember for the knee replacements and that
Mhm.
model kind of coming out
Yep,
and people talking about it. And I was like, look, I get it. I'm a private practice. There's no incentive for the hospital to refer those patients to me
yep,
anymore, ever again. I understand local leadership, like the third party payer is saying, we can't manage everybody everywhere all the time. So let's put some local responsibility on the hospital because they're there, and let's hold them accountable for what happens to that individual. And I genuinely think it's a good model. Just like I think physician owned physical therapy clinics are a great model. If I was a patient, I would want my physical therapist working with or for my orthopedic surgeon. Like, it makes total sense. I understand it from that perspective. I didn't realize, and this goes to show like how we've got the blinders on. I never really think about, oh, physical therapy in a hospital setting is more of an expense than any benefit. We're not bringing in revenue per se. Even in
mhm,
my Medicare course, I show like my local hospital here, they have their pricing publicly available. It's
mhm,
$587 for an evaluation, $268 for a single unit of ultrasound. It's
mhm.
just crazy pricing. So we see that and we get so wrapped up in, oh, the hospital's making millions. But in
Yeah.
reality, and I'd be curious to hear what you say.
Mhm,
When I think of where most of the money is, it's not an
mhm.
outpatient. I would imagine most of the money is in inpatient settings, hospital-based settings, skilled nursing. And so that's where the influence is as well. Like, we're way out on the periphery.
What great point. And payers, okay, this really shakes people's minds. Payers don't want that to be the case. Payers want the money on the outpatient side, right? And this goes to this incentive conversation. If you understand the opportunities and what payers are thinking about, it starts to take on even more of a life in terms of what the opportunities are for outpatient therapists. In a hospital outpatient department, they're billing because that's the outpatient department billing cycle. It's a different payment system. The OPPS versus the IPPS is the hospital inpatient system. But yes, therapists are cost centers in all Medicare Part A billing. We are not revenue drivers at all, right?
Yeah.
And that is, therapists don't like hearing that, but I think it has actually taken power away from therapists to really unknowingly be in that place, right?
Right.
They're seeing more people. Yes, I mean, you want to make sure if there's a lot of referrals for therapy, you're getting to those referrals. But it's not because that's going to bring more revenue to the hospital. It's because you don't want to leave referrals that, aren't being met out just hanging to dry. So it's always in any setting, it's about having just enough therapists, right? Just enough
Right.
therapists to do what it is that's required of them. And I don't want to make it sound, so horrible that like
Sure.
therapists aren't valued. It's not that they're not valued, it's that they're valued for the role that they play as part of the team, but not as a revenue driver. So when you're not a revenue driver, your voice is muted. It is mute. It's not the same as all the other departments that drive revenue within the hospital or wherever it is. I will say too, on the just to circle back on the joint model, one of the things that I did, right, as a PT, running the CJR, the comprehensive care for joint replacement model, is despite the home health agency not wanting to give up the business, we knew that a good percentage of the total joint replacements could go hospital to Med B in the home or Med B outpatient. And so we worked with our own home health agency and then others, wherever we could find good Med B providers that we would send them instead of the patient going to home health, even because even that, right? You're giving patients what they need and you're probably giving them better, in some cases, better care. If you don't need a nurse and you're not necessarily homebound, you can have just Medicare Part B in the home therapy. So that's becoming more and more popular. And as there's a new model coming out that if we have time we can get to, another episodic model coming out, CMS actually put in the final rule, so the regulation around this model, they put in it that not just outpatient physician practices, but outpatient therapy practices can get into contracts with the hospital so that they can be at risk providers. In other words, patient comes to therapy, they do a great job, they can share in a portion of the savings. They can set up that contract with the therapy clinic.
Wow.
I mean, this, I haven't spoken to any therapists that even know about this. It's
No.
right in the regulation. It's blatant. I did jumping jacks when I read it. Oh my gosh. This is one. And I had met with CMMI through my groups, the Innovation Center, who created this model and really encouraged some of the things that they did, which I thought were wonderful. And I didn't even think of this idea. Oh,
Right.
wow. Call out outpatient therapy as a contract, a provider type that can contract with the hospital. This is genius.
Yeah.
So
So
anyway, let me stop.
with that, like, that brings up a point.
Mhm.
What are you doing right now? We kind of got off track because we started talking about that. Do you
Yeah,
have a company that's a consulting company? What is your specific role day to day beside the little bit of patient care that you still do for fun?
good question. And I guess I should say I do not speak for my company that I work for, a publicly traded company. These are all my own ideas. So I now work for CVS Health as the lead director, senior director of public policy and government affairs. So I lead the public policy for CVS Health on value-based care and a lot of Medicare issues. So the policy team is part of the government affairs team. It's the lobbyists and the state lobbyists, and then the policy wonks. So I mean, honestly, it's just a bunch of really smart people that know a lot about different subject matters. My whole team that I work with are all essentially lawyers and public policy professionals that went to school for it. But there's not a lot of experts in value-based care policy. And so because I decided to just turn myself into an expert, not knowing that's what I was doing, I was just asked to join this department. And then when CVS purchased the company I was in, I went along with them, and that became my role within all of CVS.
Is this the same CVS as in like CVS Pharmacy?
CVS Health, yes, CVS Health
Okay.
is the pharmacy, the PBM, Aetna, Medicare, all of the Aetna products. Now it's Signify Health, Rubicon MD, Oak Street Health,
Wow.
and more. They are in a
Wow.
lot of different things. Yeah. So they're becoming a provider organization, not just a payer and PBM vendor and pharmacy. So it's exciting. It's
Sure.
exciting, and it's a job. I don't meet any therapists in public policy space. None, not one. I've
Yeah.
never met one.
And we hear nonstop about therapists looking for non-clinical roles to get out of patient care, to
Yeah.
find other opportunities for them. Could you share a little bit of like what are some of the opportunities you're seeing on the horizon right now that if therapists did want to move into this world that you're in a little bit, what could they do? How would they even get started?
Yeah, starting is probably the hardest part. And I got to think about it for a second because my route was so alternate.
Yeah.
I would say, I guess if you're either in an organization, which is sort of roundabout how I started, and how I've answered this question, I guess when I've been asked in the past, is still relevant. Wherever you're working, if you're working in an organization that's, multi-layered, or even if you're just working in an outpatient therapy clinic or you're an owner, just start to learn about the rest of the health system and their incentives. And I know that sounds right, it's steps before, but it's by bringing opportunities to owners and operators, bringing opportunities that they don't know exist because they're not living in the full healthcare continuum place because they're working on their own business. If you bring those opportunities, you start to elevate yourself as an employee, as someone who's not just a treating clinician. And not that there's anything wrong with always just being a treating clinician, but again, for those looking to leave direct patient care, if you understand how your business makes money, how all of the rest of the continuum around you, other healthcare providers, how they make money, you can figure out ways to find new revenue streams that directly link therapists to the rest of the healthcare community. And I really hammer this home on a lot of podcasts the few that I've been on, I should say, because I hear so many wonderful experts in therapy talking about all these novel ideas. But what I don't hear them talking about is the rest of healthcare, right? We're this nugget. We're a nugget of healthcare that is totally underutilized, undervalued. And by the way, huge opportunities are out there,
Yeah.
that I talk about a little on LinkedIn. But by being aware of what's out there and what's happening and, just where the direction of healthcare, where it's going, you can bring those insights to your employer and policy or otherwise, opportunities open up, right? But you have to be willing to think about things outside of just the therapy clinic and the business of therapy. Does that make
Yeah.
sense?
It does, and I'm gonna put words in your mouth, I don't mean to, but I
No?
think one of the challenges is we're kind of so used to, "Okay, I'm gonna look on Indeed for the job that I
Yeah,
want." You're describing a job that maybe isn't posted or doesn't exist, or nobody even knows that you're the best person for that job, and you just need to kinda go out there and put yourself in the space.
that's right.
You said you became the expert inadvertently because you started researching and getting involved in these conversations.
That's right. I guess I should tell you this. I think this would be interesting for the listeners about how I ended up out of the health system. I had been in
Uh-huh.
that system for 20 years. And I started to reach out to people on LinkedIn that were doing interesting things in the transitions of care space, skilled nursing space. And I reached out to someone who weeks later asked me, I had this opening. Can you come fill it for me and be on this panel? Like 2,000 member skilled nursing facility, is a conference, a very big, well attended conference. Skilled nursing facilities don't like to hear value based care messages. There's not a lot in it for them on the surface. So, or at least, so me coming in, I'm the enemy, but I'm trying to give them here's what you can do to be a good partner. Here's what the opportunities are. Anyway, the third year that this conference was on, they had a different speaker on that panel in the place that I was. And I was so impressed with him. I was in the audience that time. And I just messaged him on LinkedIn and said, I'm really impressed with your message. I'm interested in moving into a different role as you're building this company. If you're looking for, other leaders, I would be interested in talking to you about joining. And lo and behold, a month later, he reached out to me and said, I'd love to interview you for this kind of figuring out what the role was. And it ended up
Yeah.
being like a client partnering strategy. And then I had to be the policy expert to figure out what are all of our opportunities that we can offer to clients and prospects. And that's how I kept building. I had to learn about every program that we could apply for as a partner. And then, that just turned into, well, now you're an expert. Once you're an expert in something, others pick up on it. That's how I ended up in this role. That's it.
Yeah, LinkedIn is such an interesting platform. I literally just got on the platform, I think August, a little over a year ago.
Wow.
I'm trying to understand, the every platform has its own kind of rules, and so it's interesting to see how many connections and how many interactions do actually happen on LinkedIn.
Mm-hmm.
Let me go back. One of the things that caught my attention the first time I heard you talk to Paul
Yeah.
from Strata PT,
Yep.
you were, I always hear therapists say, well, write letters to your congressman. And I just always have felt like, you're talking into a void that's not really doing anything. It's giving you an excuse to feel like you did something. But in reality, if you're gonna spend even minutes, let's do it with something that's gonna have an impact.
Yeah.
Um, for
I
therapists who do want to, even if they have to work at it, even if they have to learn new skills or understand new things, like, what is the real impact that a therapist can have? What is the direction they can go to really be part of some of these conversations?
I love that question. I um I will start by saying what I've said on a few times already. Leave the physician fee schedule lobbying up to the physicians and the specialty groups because they're going to be the ones that are heard, right? They're spending inordinate amounts of money lobbying for the same things that you want, right? Outpatient therapists want and improve, fix the conversion factor problem, add an inflation index. Number one, it is extraordinarily expensive for CMS to do. Tens and tens of billions of dollars a year. It's going to take a while. It's complicated. And it's wonderful for therapists to understand it, go on, even you want to join a Hill Day. But I believe in everything that I see and know that we are way ahead of the game. And what we really should be focusing on is how does the therapy profession present themselves as part of the normal healthcare system, not an outsider that only exists in our own clinics where we have to be and are very valuable. But we need to position ourselves as part of the primary care to start, the primary care team, right? And I suggest taking a page from behavioral health and stepping even from Congress. Congress is important, but what we really need to start with truly is CMS, right? We need to work with the Center for Medicare on things like here is how we collaborate on a primary care team, and here's how our involvement right immediately when someone has pain, dysfunction, gait instability, balance, yada yada yada, our presence either directly within the advanced primary care team or having a very close coordination, like care coordination codes that can be used, how that can add value. Because we honestly, to elevate this profession to a different status, and I believe we need that, and it's way overdue. We need physicians as our surrogates and not specialists. We need primary care as our surrogates. So let me take that a step further to kind of explain like why are you saying we need physicians? We don't know. We don't need physicians because we need them because we don't have direct access or we can't access patients. No, if we want the public to see physical therapists and other therapists as direct access providers, not because, regulations allow it or our scope in states allow it, but the public on a regular basis sees us as the primary person you go to, it has to start with primary care docs believing that too. And the reason there's an opportunity in that now is we have practices, physician practices, advanced practice providers going into what they call full risk relationships with payers. So, full risk just means the plan, the health plan, is going to give all of the dollars to the physician practice for all of their patients. And then the physician practice has to figure out essentially how do we care for these patients that we're responsible for better upstream. We're not going to worry about billing codes anymore. Billing codes are not important. We're going to worry about identifying everything our patients need, reaching out to them proactively, and having excellent access to care, right? They have a
Right.
pain, they have pain, they need anything, we are available. And when you take away the need to bill from a physician, right, that is not going to bring them more revenue. You then take away the disincentive to see the incentive to go there first before referring. We know we see patients direct access, but I mean, it's unfathomable the percentage of patients a primary care doc sees that belong in therapy first.
Sure.
But if we're going into something where, well, now the stakes are different. We manage these dollars, and if we manage them well, we share in savings with the plan. That is where everything's going now. And there
Right.
are therapy organizations starting to step in and offering to go into these relationships. I think what outpatient therapists could do right now, right, is to offer to work with advanced primary care practices. And even if it's only a few hours a week, offer to be on site. Start to demonstrate how you can be the person that they can hand right off to. And it's not, they know that they can't handle it well, right? What are they doing for back pain? They're
Right.
referring, sending for imaging, going to specialists, giving them opioids. If they can hand off to you, they're going to take all of that cost away, the cost that they have to pay for. They're writing the bills to the specialist, right? And their patients are getting the right care at the right time. You take
Yeah.
that concept and you go to CMS. Anyone can meet with CMS anytime, right? You book an appointment, a 30-minute appointment with CMS. They give you a time, you fill out a form, and then you have a Zoom call with them.
Huh.
And you go through how you can bring value if you can be paid in different ways. So the behavioral health providers have done this. We could follow exactly what they've done. Additional collaborative care codes, elevating what their practice means, elevating some of their licensed clinicians to higher level, allowing them to just enter into the primary care space. All advanced primary care practices now have behavioral health right on site. And you know what happens when they have a patient who is depression, anxiety, anything that requires a mental health clinician? They work with them to introduce them to that behavioral health clinician, and they're right down the hall. And they all
Yeah.
have a conversation together and they trust their physician. And now they're going to trust that behavioral health provider and they get the care they need. Right. It's a no-brainer, but behavioral health went years, they worked on this for a number of years before CMS said, okay, look, we're going to elevate the value of your codes. So when you bill the physician fee schedule, yes, the conversion factor's cut, but no, we're elevating you. They were either 3 or 4% up in the proposed rule this year,
Wow.
and a lot of primary care. So when we say the conversion factor has to be fixed, there's more than one lever there, right? We have the conversion factor cut, but that means some providers will get a cut. They're going to reweight the RVUs, the relative value units. They're going to reweight them based on what they believe the value to be of the codes that those providers are billing. And so they could cut the conversion factor, but they're going to up the work value units of that provider's billing codes. And so they're actually making more now,
Right.
right? So this is the kind of advocacy directly to CMS. Everyone else follows CMS's lead, right? All the other payers are going to follow CMS. Advocating for those steps, we begin to integrate more, and that will only escalate the value to all of our outpatient practices and the specialty practices, right? Because we need to get in the door that first way, in more integrated in the health system. I know I just said a lot, but I wanted to get in what the little time we have left.
I love it because like that is something that resonates, that makes sense to me. Going to the
Mhm.
politician first. I was never just crazy about that. Going to CMS first. Now that makes sense. Like I understand that. And even going back, man, we're going to stretch my memory way back. I remember it was one of the PT journals had published an article talking about, might have been, it was in another country where they were testing putting a therapist into a primary care office as like a triage to figure out who's appropriate for therapy, and that therapist would refer out to local providers. And it was a great success. I know even in my history, when we came to Ohio, we worked for about a year or two, just totally independent. Then a local orthopedic who specialized in spine said, "Hey, I am building a spine center. It's going to
Mhm,
be orthopedics, it's going to be
mhm.
pain management, psychiatry, psychology,
Yep.
massage, chiropractor, and we want you to be the therapy provider." And we had an integrated approach for a while where, new patient with chronic back pain would come in. I might be the one that comes in and does all of the range of motion measurements and testing and assessment. And like,
Mhm.
I had a seat at the table. Now, unfortunately, that project went bankrupt because of other poor decisions. Um, but I could see how it works, and I could see how it all comes together to benefit the individual providers as much as the patient themselves, because we could all communicate. When something just wasn't adding up, I literally could walk across the hall and say, "Hey, doc, this is what's going on. Something's not right. We need to go a different direction." Which took me back to why I said physician-owned practices. I would want my therapist talking and having that kind of relationship with the surgeon and the primary care doc and the endocrinologist and everybody else on the team. Who is the team? When you reference the primary care team,
Mhm.
who are you referencing? Who makes up that team?
So I'm gonna make sure we call it advanced primary care. It's not straight primary care.
What's the
They're not.
difference?
Yeah, so primary care, regular primary care is billing as many units as possible, fee for service, right?
Okay.
Everybody that comes in, the more you bill, the more you make. Advanced primary care says, we're not going to be concerned with billable units. We are going to own the dollars, and we trust that if we're given the tools and we have the dollars to control ourselves, that we are going to give each patient the right care at the right time in the right place. And by doing that, we're going to end up with money left over because they're not going to need the hospital and the SNF and the specialists. So advanced primary care both means team-based care, and it means what I call primary specialty care. So
Okay.
team-based care will be a physician and APPs, advanced practice providers, and then it's typically behavioral health. They usually bring RNs back in. So they have the nurses, the RNs make their own appointments. Remember, no one's billing. You're not billing codes. So if you have somebody who's a diabetic and needs to work on their blood sugar monitoring and, or someone with heart failure who, they're gaining 5 pounds a week and they really need close attention. The nurses are booking appointments and they're working and training patients to manage their diseases better. Isn't this how care should be? Right?
Yeah.
It's genius. Then they have MAs, they'll have your other typical team. They often have transportation services. And then the other piece is what we call primary specialty care. So this means by giving providers more time, by bringing in other providers that can do the right care, and think about right now, it's a lot of behavioral health, but providing that right care, you're going to offload some of the work that's better done by others so that let's talk about for physicians so that physicians can spend more time doing the care that like the Marcus Welby used to do back in the day. So that's, we're not going to send you right to the specialist because you have diabetes. We're going to teach you about it. We're going to set you up with diabetes education. We're going to do remote monitoring. We're going to bring you in once a week to work on this. We're going to offer that specialty care as a first line. And we're going to then also have electronic consults. So if we're not sure, we're going to have a direct line to a specialist that we can connect with, and they'll help us determine if this person needs to actually go out to see a specialist. This is mind blowing. And think what it means for MSK,
Right.
right? MSK spend is the most variable. It's the highest spend of any spend. And how much are we impacting it compared to what the typical referral pattern is? Ortho, 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 imaging, imaging, imaging. When you look at total cost of care spend for a population, you look at all the claims data, it's loaded with imaging, interventions, specialists. You take that away and give more to the primary care to provide richer care, you change
Yeah,
everything. We should want to be a part of changing healthcare so that we're putting a team around patients and giving them the right thing at the right time. I want to be a part of that if I'm a therapist. And
right.
only good things can come of it. I have a 4:15 meeting, so I'm
Yeah, yeah, no, we can be done. I took you over.
oh no, it's
Um,
okay.
this was amazing. This is just a taste of what everybody else needs to. Where can people follow you? What platform is best? Is it LinkedIn?
I'm on LinkedIn and I have a news. So in my LinkedIn, there's a you can click for I
Newsletter?
don't know what I have it named. My newsletter's
Yeah,
in there. I have a website that is being built and I'm going to open up developing a course. So there's more to come. But yes, just subscribe to my newsletter and you can read the old articles. I talk a lot about this stuff. It's for all providers, but I am going to do something that's more niche just for therapists. So it's kind of health
amazing.
policy for providers.
Dana, thank you so much. This
You're
was
welcome.
so valuable. Go take your other call. We will
Yep.
connect again.
Thank you so much. I
All
had a
right,
lot of fun,
bye-bye.
Tony. It was great. Bye-bye.